Major funding for Carolina Business Review is provided by Grant Thornton, an international accounting, tax, and business advisory organization dedicated to serving middle-market companies. Grant Thornton, a passion for the business of accounting. Novant Health, including Presbyterian in Charlotte and Forsyth in Winston-Salem, are affiliate heart hospitals of the Cleveland Clinic, consistently ranked #1 in the nation for heart care. Blue Cross and Blue Shield of South Carolina, proudly serving South Carolinians since 1946. And by Sunoco, a global manufacturer of consumer and industrial packaging products and provider of packaging services with more than 300 operations in 35 countries.
An attorney who had argued before the Supreme Court described his pending Obamacare case before the highest court as, quote-unquote, landmark. This same attorney went on to say that landmark is an overused term, but in this case, it exactly fits the situation. This is the most widely watched program on Carolina business and industry and public policy. Thanks for watching. I'm Chris William. And this Supreme Court case is also the first of its kind for the Roberts-led High Court. That is to say, a sweeping piece of legislation with very broad and fundamental impact on all Americans. So what will it mean when the decision is handed down one way or another? We start right there on this edition, and later on we welcome Mike Riordan from upstate South Carolina, Greenville Hospital.
Major funding also by the Duke Endowment, a private foundation in Charlotte enriching communities in the Carolinas through higher education, health care, rural churches, and children's services. And by Blue Cross and Blue Shield of North Carolina. Who's responsible for rising health care costs? Join Blue Cross and Blue Shield of North Carolina and many others in a candid discussion at letstalkcost.com. This edition of Carolina Business Review was recorded June 8, 2012. On this week's program, Dr. Graham Adams of South Carolina's Office of Rural Health, Matt Martin of the Federal Reserve Bank of Richmond, and special guest Michael Riordan, President and CEO of Greenville Hospital System. Now, Chris William.
Hello, welcome to our program. Matt, Graham, good to have you here. Happy summer. I think we can probably say that. Not quite, but pretty close. All right, Matt, let's start with you. You know, when you look at across the Carolinas, municipalities now are kind of projecting budgets for 2013, and they're finalizing a lot of those. When you back up with that, Matt, and you look at since 2008, fiscally, this country has certainly gone through a lot of pain. And who's to say that we're not, that we're finished with that yet? But have we passed a crisis stage? Do you get the sense that we're past it?
You mean as far as budget crisis?
Yes.
Well, so it's mostly a longer-term issue. So and that's particularly at the federal level. At the state and local level, I think we're past crisis, but there's going to be lingering issues. So they've done a lot of cutting. They're not, funding levels in a lot of cases, education and others aren't back where they were. And there's still a longer-term issue as well when you think of things like state pension funds, right? So those have probably been a little underfunded in recent years as well. So even though budgets are improving, revenues are picking up some, and the sort of austerity the last few years has helped, there's going to be some lingering impacts as we go forward.
Would you expect that some of these lingering impacts are piling on the massive federal debt as well as the unemployment rate? I mean, are these still going to be dampeners on the economy?
Yeah, and the federal effects are going to be around as well. So in some cases, states have borrowed money from the federal government for issues like uninsured funds to pay out uninsured claims. So they're going to have to figure out how to pay those back over time. And given
any forgiveness of loans, maybe from the feds to the states on those?
That would be a hard one to project. But as future Congresses are seated, the ongoing issues, they could consider that, but we obviously have big deficits at the federal level. And as we know throughout recent history, one solution is you push mandates, some funding mandates down on the state and local level as a way to sort of ease the federal burden. So that's a risk going forward as well. Yeah,
Graham, you're nodding because of the HHS cuts in South Carolina and the Medicare, Medicaid funding gap coming from the government. When we're talking specifically in your genre about hospitals, I mean, are we past the crisis mode from your point?
I don't think we're quite past it. I think from my perspective, I work a lot with smaller rural hospitals and rural docs. They're still holding their breath. They're still feeling the impact of a poor economy, and I think we're starting to see the light at the end of the tunnel. But there's a lot of work to still be done, and a lot of changes that need to be made around reimbursement for rural providers and things like that. I think that'll help in the long run.
Let me stay with you for just a second. We're going to ask Michael Riordan later on this Supreme Court decision. And Matt, I'd like you to weigh in on this as well. I know it's a little bit out of your wheelhouse, but you're an economist. You have an opinion of some sort.
That's right.
I'm sorry, we're a recovering economist. The Supreme Court decision, due this summer, due in June. Is there, and Graham, when you talk about the small and rural hospitals, specifically in South Carolina, is there a modeling that's done within your association or within your group to say if the High Court upholds how the new law is written, or if they reject it, we can go this way, we can go this way? Is there any way to project one way or another how you're going to come down on either side of this?
I don't think so. I think if it is repealed, it still leaves rural communities, rural employers, and individuals that live in underserved areas. It leaves them in a very tough spot because, as I'm sure you're aware, most employers in smaller rural areas in both North and South Carolina, they tend to be smaller employers. They don't tend to offer health insurance on average, and health insurance is not affordable for a lot of those folks on their own. Healthcare reform at least offers an opportunity for folks to engage in trying to purchase insurance through the exchanges, and it also offers small employers the opportunity to get some tax credits to offer insurance. If the healthcare law is repealed, it really doesn't help those folks very much. They still don't have an option available to them to really access affordable coverage. And not that insurance always equates to access, but I think that at least with something in place that health reform would offer, it does give them the opportunity to kind of compare apples to apples, to look at healthcare plans and to shop and see what's available. Absent of that, they still have the same problem of not having insurance available to them, and often that does equate to access.
You know, Matt, no pun intended, but could this healthcare ruling, one way or another, from the Supreme Court, could this be a body blow to the economy again? I mean, whichever way it goes, just from the uncertainty standpoint?
Yeah, that's the thought that occurs to me about the short-run impact. So you have a whole industry that's sort of gearing up to respond to the kind of phased-in elements of the healthcare legislation, and now this sort of says, well, we may not go in that direction. We may end up having to do something else. So I think there's two parts to the uncertainty. It's we were headed one way, and we may have to go somewhere else. And then I think if parts or significant amounts of it are struck down, it's the uncertainty is, well, we're not doing that, so what are we doing? Because the issues, you mentioned access is one, and the one that kind of looms for me is the cost issue. We've got to find a way to get our hands around that. I mean, there's that longer term, we're back to talking about fiscal issues for state and national governments, right?
Right.
That's the longer term impact. And so we've got to find a way to somehow get the cost issues under control.
You know, I wasn't going to go too deep into this, but Graham, do the small and rural hospitals they certainly have a different point of view than, let's say, Greenville hospital system or one of the Carolinas Healthcare or Novant or one of the large ones.
They do.
But do they have a particular insight that maybe we ought to be looking at a different way to look at, I don't know, instead of completely resetting the system like might need to be done, are the small hospitals doing something that's more cost effective or more efficient or more proficient or something?
I think that you can look at the quality outcomes of a lot of smaller rural hospitals and see that they are just as good or better than those same procedures that are offered in larger facilities. But I think in general, you see folks in rural communities, not just hospitals, but specifically hospitals, that really just do more with less and have created some really unique opportunities around partnering with other players in the healthcare sector, physicians, local EMS, other players, to really get some economies of scale at that level that you may not always see that level of cooperation in a larger metropolitan area. But, you know, so I think so much of the how a local healthcare system operates at the local level is quite different from a Greenville or a Raleigh or a much larger system like that. That they have different issues, but I think the folks there are very committed to try and solve them.
Yeah, just a different point of view. Matt, I'll give you the final, literally, minute here. It's a little bit more farther afield than what we've talking about, but the European debt drama continues to go on. How much of this can actually affect the momentum that we have in the Carolinas? Is this a problem?
It is a problem. So there's a couple of channels through which it might have an impact on the U.S. economy. The first one you think of, given the financial nature of what's happening, is through the financial channels. So there's a lot of concern that European banks have exposure to the countries that are struggling with their debt loads. U.S. banks are a bit insulated from that, but that's not to say that you can't have some effects from sort of the contagion if European banks are in trouble, and then the whole financial system kind of has an impact. But we should be okay on that front. The other one is through the export channel, and we're already seeing evidence that exports, and in the Carolinas, a lot of exports do go to Europe. We're seeing signs that exports are starting to decline, particularly to Europe. So that slows our economy down.
Could it be a dramatic effect in the next 12 to 18 months?
It could be a significant impact. I don't think that by itself, unless you'd have to go to a worst case scenario for that by itself to sort of pitch the U.S. economy into a recession. But you know, we're kind of knocking along about 2.5% growth on average, and when you have variations around that, you can have periods that growth is so slow it almost feels like a recession, right? There's not enough job growth to really move the economy forward. And I think that's the concern, is given some of the other uncertainties, including what we've just talked about, and then you throw on the European situation, throw on slower growth in China and India and some other places like that, and you start to get several factors that together present a risk. I still think a recovery, kind of a slow growth scenario.
Double dip? No double dip?
That's not the baseline. I wouldn't see that as the baseline for the U.S.
Well, it seems like a good segue coming from one of the Fed's representatives here too. The Fed Beige Book came out recently, and one of the issues in the Fed Beige Book was travel and tourism. And that looked pretty healthy. Next week on this program, we're going to have 4 experts on that who have been on this program. At least 3 of them have been on this program before. Lynn Minges is the chief travel boss in North Carolina. Kit Kramer is the president of the Asheville Chamber, and Kit will be here along with Brad Dean from the Myrtle Beach Chamber. He's been on this program more than once or twice. And then also from Greenville, South Carolina, from the Convention and Visitors Bureau, Chris Stone will be joining us as well next week on this panel and on this program. You know, the largest healthcare providers are usually great laboratories for a lot of things, but certainly to gauge and to watch change, especially when it comes to gauging the rate at which that change occurs. Joining us now is the president and the chief executive officer of one of the Carolinas, and certainly, in fact, the nation's largest network of healthcare providers, Michael Riordan, from the Palmetto State's Greenville Hospital System. Mike, welcome to the program.
Thank you.
Well, you've heard some of the dialogue prior, and we were talking on camera or off camera a little bit, Mike. When you think about what the Supreme Court justices are thinking about now, how do you model, how do you plan for one eventuality or the other?
Yeah, so there's a step back. So let's remember why we're doing this. 50 million uninsured, and businesses are saying healthcare is driving us crazy. We just can't afford it. So that's sort of the background. So if you look at that, then it's sort of like a who's covered, and then is it how is it covered? So from a who's covered standpoint, the current legislation, or the legislation that is being looked at, will expand coverage to and underinsured. All right. So what's the impact on us? So we have looked at that. So just like any business that your viewers deal with, they have certain lines that make money and certain lines that don't, and they have shrinkage, right? Mm-hmm. So when that occurs for us, well, what do? We charge you guys a premium, and then we subsidize that. So the one thing that we see happening, if this goes forward, is that sort of levels out, because the or underinsured, there's now a payment stream for it. So we think that could be sort of one potential. Now, on the second side, from a business standpoint, it's unsustainable. So I saw a graph that,
As it is, it's unsustainable?
oh my gosh, I saw a graph that said if you bought an orange today and it went at the same rate of expense increase as healthcare since World War II, it cost $52. Right? So again, it's sort of out of control. We're making our businesses non-competitive by being so expensive.
You hear, this is interesting. You got 17,000, your head count in the hospital system, what, 17?
So 10,500 employees, but if you look at who we provide health care for, because we're self-insured, about 17,000 covered lives.
Okay, so you're an employer and you happen to be a service provider in that industry. So what is your preference?
Yeah, so...
Do you want it to go forward? Do you want the Obamacare plan to go forward, or would you like to see some kind of modification of it?
Yeah, so there's always going to be an opportunity for modifications. Do I like the fact that it has started a conversation around the uninsured or underinsured? Yeah. And does it potentially, and I don't think it went far enough in the framework or the groundwork to reduce costs? I like that a lot. So for us, and like other big employers, we're looking at, how do we reduce costs? So there's a bigger focus on wellness. Yeah, how do you get people more engaged? How do you do health risk assessments? And what we're finding is, just like in businesses, it's that 10 or 15% of our employees are 60% of the cost. So how are we managing diabetes, congestive heart failure, and some of the other things? And if we did a better job on that, you wouldn't have the catastrophic costs later on.
So Chris calls me a recovering economist, and I'm not recovering at all. So when I hear you talk about cost savings, I think along the lines of incentives.
Yes.
And I'm wondering from your perspective, either within the healthcare legislation or out, sort of what are the lower hanging fruits? How can we get more incentive structures to kind of get the cost? And to my mind, things like price transparency. I don't, as a consumer, I don't know what healthcare services cost.
Yeah. So a couple things with that, because I think that's key. So, and I think this is the dilemma for us. So our business model's changing. We right now get paid to do stuff to people. We hope it's good, and we get paid. We get paid by the procedure, right? So when costs are reduced on that, what's the tendency? You do more, so the hamster runs faster than the wheel, right? So we've got to sort of switch that. I was talking to somebody, I said, imagine if you went from getting paid per tire to all of a sudden you said, we're going to pay you per 100,000 miles. It's a different set of incentives. We have to align the incentives of our physicians and the systems so that they're not incentivized for doing more, but they're incentivized for wellness, which doesn't mean doing less or keeping out, but a different way to look at it. So, and we've got to be able to live in both of those worlds at the same time. I think this is going to be incredibly complex. So transparency, really good, but it's more than just price. It's utilization. If somebody charges $1 more per procedure, but they do half as many, that's a good utilization or a good value. So I think you're finally going to start hearing me and other hospitals have talked about is the value proposition. How do we sort of look at quality and cost?
Do you get to, I'm sorry, let me jump in here for just 1 second, Graham. So do you get to reset the way that you charge? Can you do that now?
Yeah, so charges, this gets complex. Charges have very little to do with what we get paid because so much of the stuff is negotiated.
Right.
I think what we do have an opportunity to do is to work with the employers to say, hey, this is what you spent last year. Let's do some of the stuff you're doing. Let's figure out a way to get wellness more involved, to get case managers more involved with those employees that really might be heading in a bad way. So to
preventatively?
Avoid, yes,
Graham,
and proactively.
Sorry. I interrupted you. Graham?
No, you're fine. Mike, what opportunities do you see? The ACA has talked about bundled payments and basically instead of paying the hospital and the physician in every different sector of the healthcare system a different payment for what they do, paying one payment collectively and having everybody's incentives align more or less. What kind of opportunities do you see there? What kind of challenges do you see there from a larger health system point of view?
So it's a good step. And so I think what you're seeing us do So when I got there about 5 years ago, we had, maybe 200 employed physicians. Now we have about 700. All right. So in a good way, it's integrating the delivery system, the hospital, with the physicians, so that you can do just what you said, align the incentives. No one's coming to see me, they're coming to see them. So how can we make it so that we can work on quality issues, we can work on cost issues together? So I think you're going to see that more and more occur, even in the smaller hospitals. And then the bundling, for us, it makes it administratively sort of an easier thing to do, rather than getting money to us, and we got to figure out an independent physician to give the money to. If we're all sort of together, it's beneficial that way.
Has the upstate explored an accountable care entity and the thought of trying to form one?
Yeah, so about 3 years ago, when we looked at what are our 3 to 5 year goals, we said become an accountable care organization. All right. I've sort of retreated from that language because that language got tied up in the legislation. So it just started having sort of a different feel, and it was a distractor. And now we start talking about what's sort of the value proposition. So like I said, how do we interface with the businesses? What can we do to make it healthier? And if there is something that we can do at a state level, and we're, I think, working on some pretty innovative stuff with the state around Medicaid, with Medicaid managed care and Blue Cross Blue Shield, then we're in, where we're actually going to go at risk, take less than what we had in the past, and see if we can come up with a better model. So my view on that was dip our toe in some of these small ones, and even if we mess it up, at least we start getting experience with a whole different payment methodology or a way of thinking at it. So I'm looking at sort of like little micro experiments and hoping my board is patient, because when the business model changes, there's a real gap. And we're seeing this nationally. So inpatient admissions go down, revenues go down. So how do you adjust that? We've said, let's play in that space. Let's see if we can make that work.
And let's stay with that for just a second. You know, the ratios have flipped on your outpatient revenue and your inpatient revenue. Is it always going to be now that inpatient is, I mean, inpatient is your revenue. I mean, that's the one you want to grow, right?
Yes, so maybe, right? Maybe in that old model, which will still be there. I mean, there's always going to be some component of fee-for-service. But in the new model, no. But you're right. Our outpatient revenue, about 2 years ago, for the first time, outpatient revenue exceeded inpatient revenue. And now that's happened at other systems, and some of that's medical advances. So a procedure that would take 2 or 3 days in the past, now it's less than a day. So there's some outpatient components there, but we're seeing that occur more and more. So I think that's the way to go. So that's why the network concept of having physicians out there is important for us.
So I'm interested in kind of labor force issues you might be facing now in the future, and the context being, you know, nationally unemployment's above 8%, in Carolina is much higher. Yet we still hear, and I hear these stories a lot from certain employers, that they have openings they can't fill. Now, you're standing up a new medical school, so presumably you want to have a supply of doctors down the line in the region. Are there other areas that you're concerned about staffing, either short-term or longer-term? Yeah,
so first, one, back to those 3 to 5 year goals. I'm a big fan of goals. The other one was, what do we do around academics? And we called it workforce development. So you look at the numbers from a physician standpoint, the projections are, you know, I'm getting older. People are getting older. We're going to need more physicians. The median age in the Carolinas, I think, for physicians is in the mid-50s. So there's going to be a group that will be retiring. So what are we doing to replace that? So that's the one thing. Another area that certified registered nurse anesthetist, tough one to say, a tough profession to get. So with University of South Carolina, we started a program up in Greenville, had 5 in our first class. 3 of them will come work for us. This was a group that was hard to get. We're seeing it around case management or social workers. So much of the continuum of care is you got the patient there. How do you get them into the resources out in the rest of the community? So that's another big one.
Mike, I'm going to have to stop you there. We ran out of time, but you'll have to come back because we want to talk about that. We certainly want to finish that.
Yeah.
But also the whole USC Greenville campus, the tie-up with USC. Want to hear more about that. Yeah. Please, would you come back?
Yes.
Yeah, okay.
You're right down the right of the road.
Thank you. Yeah. Thank you for being here, Michael.
You're welcome.
Good to see you. Graham, welcome to the program.
Thank you.
Matt, always nice to have you on
Thank
here. The last few seconds, and it's not enough time, but we want to send our most sincere sympathies in regards to the family of John Medlin. Here was one of the Carolinas and this nation's best bankers, and he passed away this week. Our condolences. Until next week, I'm Chris. Good night.
Major funding for Carolina Business Review was provided by the Duke Endowment, a private foundation in Charlotte enriching communities in the Carolinas through higher education, healthcare, rural churches, and children's services. Blue Cross and Blue Shield of North Carolina. Who's responsible for rising healthcare costs? Join Blue Cross and Blue Shield of North Carolina and many others in a candid discussion at letstalkcost.com. Grant Thornton, an international accounting, tax, and business advisory organization dedicated to serving middle-market companies. Grant Thornton, a passion for the business of accounting. Novant Health, including Presbyterian in Charlotte and Forsyth in Winston-Salem, are affiliate heart hospitals of the Cleveland Clinic, consistently ranked #1 in the nation for heart care. Blue Cross and Blue Shield of South Carolina, proudly serving South Carolinians since 1946. Sunoco, a global manufacturer of consumer and industrial packaging products and provider of packaging services with more than 300 operations in 35 countries. And by viewers like you. Thank you. Promotional consideration provided by Business North Carolina Magazine. For more information, visit carolinabusinessreview.com.